I always had a problem with extracting teeth, not a problem technically, ethically. If highly damaged teeth get properly treated and correctly maintained, they are always going to outlive implants. So what I'm referring to here is that most sophisticated and complicated solutions are not always the smartest one. It's not about most expensive. It's not about most advanced. It's not about most complicated. It's about the best possible for the patient. We must keep that in mind, that there is no such thing as a master key that opens up all of the doors for us. Surgical extrusion, over the years, it actually was presented to dentistry in early 80s. They were really trying to work on surgical extrusion, and guess who comes out? I have done over 200 cases with a follow-up of up to 6-7 years. That is something that you can rely on. In such cases, I take out the tooth and rotate it and put it back in.
No way.
Yeah.
So you have a retained root and you think this is hopeless and you're headed towards an implant, a denture, a bridge, or whatever. But then this episode comes along and reminds you about the power of the surgical extrusion technique. In plain terms, you are partially extracting the root, and now you have the most important thing in restorative dentistry. You have ferrule. You have tooth structure you can now crown, whereas before everything was subgingival and it was impossible to restore. Hello, Protrusive, I'm Jaz and welcome back to your favorite dental podcast. This is the podcast where we make dentistry tangible and make you fall in love with dentistry again. 4 years ago, with Dr. Peter Raftery, the endodontist, we spoke about this very topic, the surgical extrusion technique. I'll put that episode in the show notes because that was really valuable as well. But in this episode, it's special because it's an update from someone who's done more than 200 cases. So what he believes, and what I also believe, is he is the most experienced clinician in the world when it comes to the surgical extrusion technique. I haven't seen anywhere in the literature to the kind of numbers that he's done. So much we can learn from Dr. Vala Seif from Iran. And Protrusive, you're going to absolutely love him, right? His storytelling, his analogies. I actually really geeked out and had a great time, and I know you can love him. Even all the way to the end, the last few seconds, he still gave another tip of how to stop bleeding when you do this technique, so you can then add your composite splint to secure the root. He'll give you that right at the very end, so make sure you don't miss any of this episode. Now, every PDP episode, I give you a protrusive dental pearl. This one's a occlusion conceptual one, a biomechanical one when it comes to restorative dentistry, but it's also very relevant to this episode because a really cool, fascinating technique was advised by Dr. Seif, which I really am excited to share with you. So firstly, conceptually, the pearl I'm giving is to remember the following: that when you have supragingival structure all the way around 360 degrees, we call that the ferrule, something a crown can grab onto. And it's important that this ferrule is as tall as possible vertically, ideally 2 millimeters plus, but it's also important that the tooth structure remaining is thick, because if it's paper thin, that's not really a ferrule, that's not really contributing biomechanically. Now, the conceptual pearl I'm giving to you is to think about the position of the ferrule. If you have 3 millimeters on the palatal side and 1 millimeter on the buccal side, then this is still pretty good, especially for upper teeth, because the location of the ferrule is actually really important. Think of the way that the upper incisors are loaded in a class 1 and class 2 patient. When a patient is chewing, the palatal of the upper incisors is taking load in clenching, is taking load in mastication and chewing as the food is pushed into the centrals, and as you are cutting and incising, the crown is kind of going in a buccal direction. The tooth, the crown of an upper incisor, is heading in a buccal direction, and so it's trying to grip on to that palatal tooth structure. And in a lower incisor, the buccal part of the tooth structure is going to be under more strain because the lower incisor is trying to bend inwards. So why is this important? Well, pragmatically speaking, if you have a scenario where you're trying to restore a canine and you got lots of tooth structure palatally and not very much tooth structure buccally, then probably you're going to still be okay, because it's that palatal tooth structure for an upper tooth that's usually more valuable and more precious. It just helps us to remember that how teeth are loaded in a biomechanical way. Now, the absolute fascinating thing that Dr. Vala Seif spoke about is, let's say you have a scenario where you have a retained root, like a crown root fracture, and let's say you have loads of tooth structure buccally, but you don't have much palatally for an upper incisor. Remember, upper incisor, we want more palatal tooth structure. Well, the fascinating thing that he spoke about is, let's say you do the surgical extrusion technique. You partially extract this tooth out, and so now you've got more tooth structure to work with. And don't worry, the entire protocol will be broken down in this episode. But the thing he said, which really wowed me, was, okay, you have this scenario, but how about now you partially extract it and then you basically twist it 180 degrees, and that's the new position of this tooth. Suddenly, you've gone from a situation where you had a lot of buccal tooth structure and not much palatal to now rotating the tooth 180 degrees, and so now you've actually created ferrule palatally for this upper incisor. I thought, wow, that's really clever. Because guess what? The PDL don't care if it's the buccal or the palatal. The PDL don't know. The healing mechanism will still be the same. But now you've gained a biomechanical advantage. So thank you, Dr. Vala Seif, for sharing that. And I just want to just talk about it because it was just so awesome. It blew my mind. So dear friends, let's check out this main interview. I know you're going to absolutely love it. And I'll catch you in the outro. Don't forget to pay close attention so you can get 80% in the quiz to get your CE credits. Dr. Vala Seif, thanks so much for joining us today. Where are you from? Where are you speaking from?
Thank you very much for having me. I'm very glad to be here today. I'm based in Tehran, Iran, and obviously I'm from Iran.
Well, I appreciate you joining me. I try and think, have I had any guests from Iran before? I don't know. I've had lots of, I got lots of Iranian friends. I love Iranian food. I love you guys' food. You know what my favorite thing ever to see on TikTok? Like my TikTok, I rarely go on TikTok, but when I do, I just see that the algorithm knows what I love so much, right? It's that giant like rice dish that you turn upside down and you take off, right? Like, is that an Iranian thing?
We do have something similar, but what you're referring to more sounds like Arabic food. But you actually can find a lot of similarities between the food that we are making in Iran and Arabic countries, and obviously even Pakistan and India. So the taste is very close. There's a good chance that
I love it. I mean, Indian food, I love biryani, but when I see the Iranian cuisine, the kebab and stuff, man, I'm a big fan of that. But it's great to be speaking to you from Iran. We're talking about surgical extrusion today, so very excited about that. But just give us a bit of a background on yourself. Are you a restorative dentist? What is your background? What is your passions within dentistry? How did you fall to get to the stage where you'd like to talk more about surgical extrusion?
Yeah. All right. I have been working I got into university in early 2000. So basically, I'm a graduate of 2008. So almost 25 years ago, I got into dental school. So after that, I actually completed a course in Master by Research in Oral Surgery. And then I am a former resident of oral and maxillofacial surgery. For some reasons, I had to stop the training for family matters. And I have been in private practice for the past 15 years almost.
And what do you love? What aspect of oral surgery do you enjoy the most? Is it wisdom teeth? Is it implants?
Area of interest is cosmetic dentistry and implants. So basically in my clinic, I'm working on ceramic and porcelain veneers and also implant dentistry. But my passion for surgical extrusion started about 7 years ago because I always had a problem with extracting teeth, not a problem technically, ethically, basically. So that was when I was exposed to surgical extrusion because it's actually a very forgotten type of treatment in dentistry. And I was very glad when I realized that you also shared the same passion as I have for surgical extrusion because it's going to save millions of teeth probably if it becomes...
It was approximately 7 years ago when I came across it as well. I think that's when some of the research, some of the Italian people were talking about it a lot more. Now recently I've been on an orthodontic extrusion course actually. So that was by Dr. Guido Fischera. I'm probably saying his name wrong. I mean, what a genius guy. And so that was really cool to learn how to use brackets to rapid orthodontic extrusion. But you know what? On a real term, to have the materials, to have the patience, to have the technique to be able to do orthodontic extrusion, whilst when you compare to surgical, I do think it does have a lot of benefits doing the orthodontic, but it's not accessible to every single dentist, right? It's more difficult to get by, and a lot of patients will not accept having brackets of any form. So I do like the more instant, if you like, potential of surgical extrusion. So I guess the best place to start is define. Let's define, what is surgical extrusion? And then when we go from there, we'll talk about, okay, what are the earlier ways, 7 years ago, 10 years ago they were doing it, and what changes may have happened. And I'd love to obviously learn about your protocols, but let's start with that. What is surgical extrusion technique?
All right, Dr. Jaz, I'm pretty sure this is going to be a wonderful chat between you and me because I have a lot to share with my colleagues. The first thing is we look at surgical extrusion from two different angles. One is technical, the other one is ethical, or basically the philosophy behind doing surgical extrusion, right? So number one, technical is that you are going to, through a very delicate surgery, you are going to reposition the tooth more coronally in order to have sound tooth structure with a 360-degree ferrule, as well as doing it in such a way that you are preserving gingiva and PDL and bone altogether. And the reason that I'm a very big fan or defender of this idea is that many beautiful, great articles that I can share with you later are referring to this fact that if highly damaged teeth get properly treated and correctly maintained, they are always going to outlive implants. Mm-hmm. So body is going to outperform titanium in any given circumstances.
I totally agree. And I think implants are not the panacea we once thought they could be. And we're seeing so many more complications, peri-implantitis. Implants are great when you have a gap and there's no other options. But when there's one more chance, and we'll talk about case selection later, when there's one more chance to work with nature in a modified way, I guess, in an enhanced way, then let's take that, because it's so much better to have an implant when you're 50 or 60 than an implant when you're 30. And that's I don't think even the most astute implantologist in the world will agree that for their own daughter, for their own mouth, they like to save their teeth for as long as possible.
That is very true. And that's when the philosophy behind the treatment comes up. Let me put it this way. May I give you two simple examples that is going to help us understand this philosophy better? You know that when NASA engineers were trying to send man to the outer space, this is a funny story. It's an interesting story. They were trying. There was no gravity. And they were trying to make sure that they're going to find a way to, when the astronauts were trying to write down the information necessary, there was no gravity, so the ink could not flow to the tip of the pen. So there was a project, thousands of dollars they were trying to spend to make a pressurized pen. And I'm sure you know how the story ended, right? The Soviets used a pencil. And I'm going to give you I'm going to give you another example. It happened in my country many years ago. There was this company, they were making very nice chocolates and exporting it to the European countries. And there was a small problem. This was actually happening around 50 years ago, 40 plus years ago. And the small problem was this. Some of the chocolate packagings, they were actually empty. So the machine was doing the packaging, but there was no chocolate inside, so there were some complaints. And the board of directors sat together and they were trying to find a way to solve the issue. There were devices to detect the faulty packages, to get them out of the line and everything. And one day, the board of directors were actually walking through the factory to locate a designated area for the machines. And they were realized one of the very old workers of that company who was there for so many years, right in front of the rails that take the packaging to put in the boxes and everything, he actually put up a stool with a fan. So the fan was actually the air that was flowing toward the empty packages, because they were very light. There was no chocolate inside. The empty packages were flying away. And the board of directors were actually very surprised by the fact that they were ready to spend thousands. So what I'm referring to here is that most sophisticated and complicated solutions are not always the smartest one, are not always the best ones, are not always because as dentists, we are trusted that we are coming up with the best decision for the patient. It's not about most expensive. It's not about most advanced. It's not about most complicated. It's about the best possible for the patient. So we are working in patient's best interest. And surgical extrusion, I'm not against implants. Please keep that in mind that I am a big fan of implants. It is one of my passions. I do implants every day in my practice. Sometimes implants are miracles, but we must understand one thing. If we are having weapons in our arsenal, if we are having tools in our toolbox, in dentistry, veneers, onlays, inlays, implants, surgical extrusion, bone grafting, we must keep that in mind that there is no such thing as a master key that opens up all of the doors for us. We must keep that in mind that each and every one of these tools are going to be great for us and for the patient if the case selection is correct, picking up the right tool is correct, applying it is done correctly, and at the end of the day, we are having promising long-term results that we can completely rely on. That's the fact.
That was so eloquently put. I absolutely love the stories that you weaved in there to really drive home the point there that we don't need complicated solutions. Sometimes we need to look to simplicity. And so you led very nicely to case selection as well. So which teeth, where in the mouth is this technique suitable? And there must be some radiographic markers of predictability. There must be some clinical markers of predictability. Do you mind just going through which is the ideal case for whether it's your first case, your 500th case, universal principles to adhere to?
I have worked on over 200 plus cases. It's not 500. And
200 is a significant amount. For a very niche technique like this, that is a lot. You know, you're probably up there in the top 5 in the world probably who's done this technique so many times, in my opinion, based on it's to actually find the case that's like, sometimes you're like trying to find the perfect case to do this on, and then you have to wait for that case to walk through. To get 200 is a significant number.
Dr. Jaz, I'm very honored to say this. Based on the searches that I have done through literature, actually, this is the biggest data set in the world. I'm really honored to say that no one has done this before, because if you browse through all of the articles that have been published before, many of them are actually just case reports. The biggest ones that I have come across are 50 plus or near 60 teeth. The rest of them were 10, 20, 30 cases. Normally, there is no follow-up for a long term. But because I had enough time and I have done it in my practice, and these are the patients who are always showing up to make sure that everything is okay. In a university setup, it is different. Sometimes you cannot call the patients back. But I have done over 200 cases with a follow-up of up to 6-7 years. That is something that you can rely on. Anyhow, back to your question, case selection is extremely important, because if the case selection is not done properly, you are actually getting ready for big failures. As there's this idiom, if you fail to plan, you're planning to fail. So basically, number one is we need to make sure that, number one, the root length should be proper. Meaning is, after you have done your extrusion, after you have removed the decay or the fractured part, you need to make sure that after everything is done, the crown root ratio of 1:1 is going to be there.
So what we're looking for is that by the end of it, you're not having a crown that will be longer than the remaining root. So the first thing that comes to mind is someone who's already had orthodontic resorption would be then a bit more difficult, and also someone who's had periodontal disease. So whether they lost the bone or whether they lost the root from the apex, i.e. the resorption, or they've lost the bone from perio. But usually these perio cases are not the ones that will come in your clinic with the fracture at that level, because usually the mobility cushions it and all that weakest link theory. So yes, okay, that's a good point. So 1:1 is, obviously, if you're better than 1:1, if your root is longer than the crown, that's better, but minimum 1:1. That's a very good starting point.
All right. If we want to go, let's put it this way. If we want to look at the indications of doing this treatment, number one, some of the teeth, actually many of the teeth with, they say, severely decayed, non-restorable teeth. So that is number one. Number two is crown root fracture. Number three is even external resorption. All right. These are the cases that I have done, and it worked wonderfully. So when you want to pick the cases, crown root ratio is important. Number two is you don't have to have active perio problem. Number three is that you don't have to have active infection. We will get there. Number 4 is this is done especially to the colleagues that are going to start doing this for their patients. It is important to know that this extrusion works best for single-rooted teeth, all right? And when it comes to morphology of the root, we must understand this. In order to be able to extrude the tooth properly, the shape of the root has to be conical. Otherwise, if you have a curve or you have hypercementosis, it is very difficult to get the root out, so it's not going to be atraumatic. So if you cannot do it atraumatically, please don't do it, because we are negotiating with the body to talk the body into accepting something again. And these are the important parts when you want to pick the cases. And obviously, if we go further, I'm going to explain how we deal with infection and other problems.
Okay, so it's central incisors, lateral incisors. The only thing I'd probably mention here that you haven't mentioned yet, and something that you, with your experience, you'll know very well, is just a marker of predictability and success for the future could be some occlusal factors. Because if the patient, for central incisor, if the patient is very class 3 or class 2 div 2, a deep bite, then already, like, yes, you extrude the tooth, but you're extruding the tooth in a mouth, which is going to be putting a lot of biomechanical loads as well. And so therefore pre-restorative orthodontics. But then if you're doing orthodontics, you may as well extrude orthodontically. So I think maybe just having a good enough occlusion that you do all this effort, that is going to be working. But that's like a bigger global thing. Same thing like oral hygiene. You want a patient who looks after, like you said, no periodontal disease. And those are some wider factors. But when you are assessing for the case selection, is it just enough to have a periapical? Or what do you feel as though the need for a cone beam CT scan to do a proper assessment of not only the morphology in 3 dimensions, but to be able to do this treatment with success?
All right. Number 1 is, yes, CBCT is always helpful, especially when you are coming across a patient who you feel or you see that the bone is very thin, the biotype is very thin, so it's always better to get a CBCT. However, if you allow me, I'm going to have a very small comparison between surgical extrusion and orthodontic extrusion. If I may,
great.
Or if you want to postpone it to the other part.
Let's talk about it, because we're talking about what it was. You give some case selection, so it's totally fair to look at the alternatives. Because yes, one alternative is you extract the tooth, you do an implant or denture or a bridge or something. But the other good way to work with the biology is orthodontic extrusion. Yeah.
Even if you allow me, we can also bring in crown lengthening surgery, so I can explain better to the fellow colleagues how to do it. So please, you guide me. Which part of it you want me to explain first?
Let's do ortho extrusion first, okay? And then we'll talk about crown lengthening as well. I think that's a very good point.
Sure. When we are doing orthodontic extrusion, as we have mentioned before, all of these are weapons in our arsenal. It's not that one is the best and we should throw away everything else. I have done ortho extrusion as well, but for some reasons, I find surgical extrusion more efficient and more effective. Number 1 is when you do orthodontic extrusion, obviously it takes time. And if you want to come up with best results, sometimes you need to call the patient for a fiberotomy to cut the fibers. And the other thing is when you put all of those appliances or the brackets and everything in the patient's mouth, it is more difficult for the patient to keep it clean. And sometimes because of the appearance, patients are not really eager to do so, to go for the treatment. And the other thing is sometimes when you are moving the tooth, the gum and the gingiva are also moving with it. So the end...
But the reason for the fiberotomy that you mentioned is to minimize that, to reduce that. And there are techniques for that. But yes, quite often a complication, if you don't get the protocol just right or particular biotype, then you get the migration of the gingiva, which you don't want, because you want the ferrule, you want the tooth, you kind of want a pure extrusion without the dentoalveolar complex to come with it, so you have the pure ferrule. But sometimes it may not work fully that way.
Exactly, especially if the patient is not fully cooperative, you may need to do an additional surgery. And the other reason that we are doing fiberotomy is because there is a chance of relapse to some extent.
relapse, I'm just saying for the listeners, is what we mean by relapse here is relapse, i.e. Intrusion of the tooth again. So once you do orthodontic extrusion, the tooth will go
Correct.
back in, but also sometimes you extrude, but then the gingiva will just come down thereafter, which again, you don't want to lose all that space that you gained.
That is very correct. So when you are trying to do it with surgical extrusion, it is done in one session. You get the results almost immediately, and it is much faster. You are sure that if you do it in a atraumatic way, nothing else is going to come down with it, the gingiva and the bone. And it's in terms of how it looks in the patient's mouth, the patient is actually, in my experience, they accept it better. And one more thing, as compared to other treatments like removing the tooth and replacing it with something else, in my experience, it is very interesting, Dr. Jaz. The patients are much more cooperative and thoughtful with keeping it clean because they see it as their last chance. Emotionally, they don't want to lose a tooth. So when you are giving them the warning, hey, this is the last bullet in the magazine, so please help me help you, they're very cooperative. So yes, I think for the reasons that I counted, surgical extrusion works, in many cases, works better.
I get the patient aspect for especially for those who don't want to go through a longer, regular recall for fibrotomy and the brackets and stuff. So I think it's a very viable alternative for sure. And then with crown lengthening, it's easy to say that, okay, with crown lengthening, you are removing bone quite very often, you are removing gingiva, and then therein lies the issue whereby now, if you have the gingival zeniths that are even, now one tooth will migrate up, and then you have to do it all together. And so there are some surgical considerations and complications. Is there anything else you want to add to crown lengthening as a disadvantage?
Yes, sir, absolutely. Dr. Jaz, when we are doing crown lengthening surgery, especially in cases that are high lip lines or the ones who are gummy smile, a big issue is this. You are going to have a long, whitish, ugly crown that most of the patients can't live with. So that is number one. Number two is you're going to have probably dark triangles. Number three is it is very difficult to keep them clean. So here comes the issue. When you have food getting stuck there, there is a chance that the cavities or the gum problem starts again for the same tooth or the adjacent teeth. So now you are facing a new challenge. There is a risk for perio problem or new cavities in this area. And the things actually don't stop here. I am trying to bring your attention and all of my colleagues' attention who are viewing or listening to us to this matter. Let's say, God forbid, one day you have to take that tooth out. What is going to happen? Obviously, you are going to put an implant, right? What was the previous problem? You had a long, ugly, whitish crown, and you couldn't keep the area clean. So it's either putting an implant there and redoing the whole scenario. So at the end of the day, the same thing is going to happen. Implant is going to have peri-implantitis, whatever, or the adjacent teeth are going to face the problem, or you are going to have to rebuild everything that you had removed before.
Yeah.
So
it's removing the precious bone, and now you've lost it when you're lost now in terms of this scarce resource.
That is very true. So I believe that surgical extrusion, for the very same reasons that I just explained, I believe that surgical extrusion is the treatment to go in cases like this.
Right. So I think that's a very nice overview of the alternative options. And so I think what we'd love to know now is we talked about case selection. We talked about, ideally to have a CBCT would be great, but I appreciate that from what I've seen in the literature, sometimes periapicals are just fine, especially if things are looking quite straightforward and not everyone around the world has access to cone beam CT scan. And so let's talk about a classical case. And for those who are watching, obviously we're being very good for the listeners on Spotify, Apple and whatnot. For those who are watching, I don't know if you want to maybe share a case and just be descriptive for the audio listeners for when we talk about the protocol. Like step one, the patient comes in, presentation, this is what you say to them, and then that's what you do, and then how many weeks, all the nitty-gritty details.
Sure. But before we go to that, part of your question was left unanswered, if you allow me to answer to that part. You were mentioning occlusion. All right.
Oh yeah. So you're such a great guest. You know that you're amazing, clear guest. Thank you so much.
I appreciate. Thank you, sir. So what I want to point at is this. Obviously, you do implant in your practice. So when you want to do implants, especially in practices that the same doctor does the surgery and does the crown. The best way of doing it, we all know that. It's not surgically driven, it's prosthetic driven of putting the implant. Am I right?
Mm-hmm. Yes, absolutely.
So
Historically driven.
Yes. So basically, Dr. Jaz, it is kind of a reverse engineering. When I want to put implants, this is what I do. I'm going to try to imagine this, that, okay, this is where my crown needs to be in order to be beautiful, in order to be able to get cleaned very well, and in order to withstand all of the forces of mastication that are going to be implied on this tooth. Am I right? Same thing happens to surgical extrusion. Please note this, that it's not extracting a tooth. Surgical extrusion is not a simple extraction. Surgical extrusion is a very technique-sensitive surgical treatment that you are not just going to take the tooth out and put it back in and then, okay, boom, the crown comes on and everything is solved. No, same reverse engineering is going to happen. You have to keep that in mind, especially when it comes to front teeth, Dr. Jaz, because when you look at, for example, if you look at a central incisor, the upper one, or the upper canine, the tooth comes out of the gum and then there's a divergence and then it comes back and the tip of the tooth becomes smaller and smaller, right? And the root is actually very thick. So if you do not consider the occlusion or the bite, let's say I'm having a canine extruded. If I do not adjust the angle correctly, there's a good chance that a problem in occlusion is going to happen. Maybe sometimes when we are splinting the tooth, we are going to remove the excess and everything. Okay, the healing is uneventful, but when it comes to prosthetic part, then you don't have enough space to put the crown.
But from someone here, like I don't do implants, right? But I know this much, that if I'm doing an implant for the let's see, lower molar, right? Lower first molar. Yeah. I want to make sure that the implant, when it's pointing, that it's going to be going towards the fossa of the upper molar, right? Like you don't want it pointing too much buccal, so it's in crossbite, or lingual, so it's in crossbite, right? So what's fascinating here is you raise a good point that yes, when you extrude the canine or extrude the central, the sort of projection that's going to take is important to make sure you have enough overjet, enough clearance. Absolutely. It makes sense. But here's something I didn't appreciate is how much wiggle room do you have? How much freedom do you have? So when you do a surgical extrusion, let's say you surgically extrude it 3 millimeters, right? Or 4 millimeters. And we'll talk about exactly roughly how much it ends up being. But when you have it, obviously now the root is going to be a little bit loose inside the socket, right? So how predictably can you change the angulation a bit more buccal to maybe not be so involved in the envelope of function?
All right. Here's the key. As I mentioned before, this technique is done on all of the single-rooted teeth. So we're starting from the upper central incisors, laterals, canine, first premolars, provided they are single-rooted, or the forcation is very low, is very apical, and the, obviously, second premolar, same goes for the lower teeth. So when you are talking about premolars, it is okay to have the tooth extruded more than 2, 3, 4 millimeters if the root is really long and strong. But when it comes to front teeth, because we have overbite and overjets, you are not allowed to pull it out as much as you think it is okay. If you have 2 millimeters of ferrule, it should be enough for you. That is number one.
And I think it's important to talk about ferrule because we have so many episodes we have done about post-crowns and ferrule and the importance. Correct. But someone who may be listening to the podcast for the first time, a student, young dentist, I think it's really important to spend a couple of minutes to pay respect to the importance of ferrule and how it is one of the most important prognostic factors of our dentistry. So can you just tell us about define ferrule? Which part is the ferrule, and to if it's subgingival and you can grab onto it, is that still good enough to call a ferrule? Because biomechanically it's giving you something. Because some clinicians I see, they're very strict that they only see the bit that is supragingival. The clinical crown, they say that's the ferrule. Anything subgingival, consider it not a ferrule. It's an interesting distinction. Whereas I always say that, look, if I can do a vertical crown and go 0.5 mil to 1 mil subgingival, and I'm actually grabbing on to that tooth, that will biomechanically assist me, and I'm counting that as a ferrule very often. But where do you see that?
Dr. Jaz.
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
I am very, very, very careful when it comes to going subgingival. I respect the gingiva and the periodontium a lot, so I really do not appreciate going subgingival too much, maybe half a millimeter, but basically, yes. When I am doing surgical extrusion, to me, ferrule is what is above our sulcus, what is above our gingival level. So yes, to me, that is ferrule. And for the listeners who are probably younger dentists or our future colleagues or the dental students, ferrule is defined as this: the supragingival structure of at least of a minimum of 2 millimeters of the tooth with the thickness of at least 1 millimeter.
That's the bit we often forget, right? The thickness. We all talk about, okay, the vertical ferrule, but we don't appreciate the horizontal ferrule, right? Because there's no point in you having a tooth, and we've all done this, right? And you think you got 2 millimeters of ferrule, but actually the endodontic access is so huge, or the caries destructism was so huge that actually it's very thin. Correct. And it's going to snap. That is not serving you in a biomechanical way.
That is correct. And when you forget that, what happens is your post and core is going to have a wedging effect, and then you're going to have a root fracture. So all of the effort that you have put in treating something that you were not diagnosing correctly in the beginning is going to end up terribly, and you're going to lose your patient's trust.
And in your case studies so far of 200 plus cases,
Yes.
the ideal gold standard will be that you do achieve 160-degree ferrule of 2 millimeters.
Correct.
But there are some pragmatic concerns that sometimes that not maybe easy or not possible. And so in some schools of thought, like depending on the occlusion, if you have someone who's class 2, a bit more class 2, a bit more overjet, then maybe if you are getting a bit more palatal ferrule, maybe you get 2-3 millimeters palatal ferrule and the way that the tooth broke, but you only have 1 millimeter ferrule buccally, then maybe this could suffice? Or do you think that you get such good results because you're very strict? Like, how strict should we be with this 360 degrees 2 millimeters? Because sometimes the way the teeth fracture, the crown root fractures, you will end up with 4 millimeters ferrule buccally and 2 millimeters palatally, and that's great. But sometimes you get 3 in one and 1 in the other side. How strict are you, Vala?
Okay. Dr. Jaz, that is an excellent question. I'm going to give you 2 answers. The second one is going to surprise you. It's a bit, really, I've already surprised you. All right. Number 1 is you are absolutely correct, sir. In so many cases, for example, you are having a very deep cavity on the surface of the root, and you remove everything, and then you extrude, and then you realize that, okay, you cannot extrude more than this, and you cannot achieve 360 degrees, but you realize that 3/4 of the tooth is going to give you good ferrule. In that case, I have done so many, and so far, touch wood, they are in the patient's mouth, functional, clean, healthy. So it is, yes, there are some flexibilities, but please, I'm asking our listeners to bear in mind that if you want to start, please start with simpler cases. Just like when we are learning to put filling in patient's mouth, we are starting with class 1 and then class 2, and then we go to cosmetic and all that. For implant, same thing applies. So yes, there is a chance that you don't achieve 360 degrees. You get 3/4 of a tooth. That is going to be enough. And sometimes this is going to surprise you. Sometimes you realize that, okay, if I had ferrule on this side, it was better. Or if I had ferrule on that side and the other side was a part of our casting post, it was much better. In such cases, I take out the tooth and rotate it and put it back in.
No way.
Yeah.
That's so cool. Okay, cool. That's like reimplantation, like that's pretty cool. I didn't even consider that. That surprised me, but I love that because my mind always said that, okay, when you do this technique, you take it out a bit and then you obviously do the suturing. We'll come on to that and then fixation. Sure. But I didn't actually think that, okay, if let's say you have a lot of, for an upper incisor, you have a lot of buccal ferrule and no palatal ferrule, but actually you want to have that palatal ferrule to resist and then to do a 180 degree. That's really clever. I like that.
Yeah. And sometimes this is one more thing I need to talk about, because there's a chance that I forget. It's not sometimes when you're trying to extrude the tooth, you don't need to do a full extraction, especially if the tooth has not undergone endo treatment. So you just try to take it out, and once you reach that ferrule, just leave it.
Yeah, that's going to be the air time, right? Your air time is 0, right? So every time you take it out, now it's exposed to the environment that is coming against you. But I know that, like you said, if you're going to do the 180, then you can take it out, inspect it, make sure there's no cracks, that kind of stuff, and then put it back in. But I think you're going to give us some nuances now.
Yeah, that is very true. What I wanted to point out is, normally, if you have a tooth that is having a severe decay but has not undergone endo treatment, you just need to pull it out a little bit, get the ferrule, and that's it. But if that tooth has undergone endo treatment, you need to do a full extraction, take it out, do a complete, careful visual inspection to make sure that there is no perforation, there is no crack whatsoever, and then you can put it back in. This is something I didn't want to forget.
Okay, yeah, excellent point. Okay, lovely. I'm really enjoying this so far. Okay, so now let's talk about the clinical protocol, because the question that will come is, okay, when you, let's say in the endodontally treated tooth, obviously it's more than likely going to be necrotic. It will need the root canal. But
Yes.
when you do extrude it, and you don't need to take it all the way because there is no existing root canal, what are the different methods of fixation and stabilization? How long should you wait, and ideally before, in your protocols, before you do the root canal? Any considerations that you need to do. Like sometimes, like, you may even think that if you have pulled the tooth out and maybe it's come out fully by accident, in that moment in time, maybe you should get the ruler and get your perfect working length at that moment in time and put it back in. I don't know if you've ever done that, but I've heard that one before. But we'd just love to know the waiting times, the loading protocols, the temporization. Are antibiotics necessary? Last time I asked this question to a lecturer, he said, no, we don't think antibiotics are necessary. However, someone else, once I asked this, he says, yeah, I just give antibiotics. And I don't know where you lie in your protocols. And I think we can learn a lot, because something that one of my mentors, Lane Ochi, taught me is you can have all the in vitro studies in the world. You can have 500 simulations of this technique, but the one case study that you do, just the one clinical case study, is worth 1,000 times more than all those in vitro studies. So your experiences are extremely valid, because clinical experience is 1/3 of evidence-based dentistry, and so your evidence is very, very important. So if you say that in those 200 cases you did it with or without antibiotics, or you have some clinical guidelines that you've made, that is very valid.
Sure. First of all, one thing that I would love to say here is that surgical extrusion, over the years, it actually was presented to dentistry in early 80s. And the problem that it was not very popular, it did not become very popular, was that, try to imagine this. There was a singer, young, very talented, with great future in music industry, is going to be presented to the world of music and fans and everything. But I don't know if I call it bad luck or whatever. There is the same time that this guy is going to be presented to the world is going to be exactly the same time that the fame and popularity, or the explosion of fame of Michael Jackson, happens. So this guy is always overshadowed by MJ. I'm a big fan of MJ, by the way. So during those days, they were really trying to work on surgical extrusion. And guess who comes out?
I've got his name now. The Godfather implant who passed away a few years ago. I forget his name now.
Ingvar Brånemark.
Brånemark, that's the one. Yeah. Rest in peace, legend.
Peace be upon him. The implant comes out, and implant steals the show, becomes the rock star, becomes the new technology and everything. Everyone is screaming and shouting. So this little guy was pushed away. So here's the thing.
But also, you know what? It's important to mention, Dr. Seif, that a lot of things that become mainstream in dentistry are not necessarily what's the best for the patient or what's best for clinical dentistry. It's also dictated by the market, manufacturers, the industry, because industries cannot monetize. They can a bit here and there, techniques to do atraumatic extraction. We talk, the Benex, etc., that kind of stuff, right? They exist. Yeah. You can't sell lots of units of anything or market lots of units. 3M can't produce anything for, so innovative and different types. So for the industry and the business of dentistry, implants were obviously where the money of research and all the attention and the conferences and education would go to as well. It's something just worth considering.
Very true. So for the past few decades that here and there they were doing surgical extrusion, everyone was trying to do it in such a way that made sense to them. But after doing 200 cases and have a follow-up of 7 years, I have come up with a final protocol. It is called SEIF Protocol for Surgical Extrusion.
I love that because his name is Dr. Vala Seif, right? Seif is spelled S-E-I-F. So do you call it S-E-I-F or do you call it S-A-F-E?
All right. In this case, it's obviously my name, S-E-I-F, but it's still, it is actually...
It's pronounced Seif. So that's awesome.
Yeah,
the SEIF protocol. I love it.
Thank you very much. I appreciate it. So finally, we have a protocol. And in this protocol, these are the 1, 2, 3 that we should go through. Number 1 is obviously case selection. For case selection, we are working on single-rooted teeth. I have done it on lower molars. I'll send you the pictures. It works really well. It is actually similar to bicuspidization. However, you bicuspidize and you extrude.
Okay, so bicuspidize is like a hemisection, right? And then maybe you remove one of the roots, or do you keep both as 2 separate units?
All right, it really depends. For example, one of the cases that I did for one of my friends, it's been in his mouth for 2 years now. The mesial root was fine. The distal one was not. So I extruded the distal one and splinted to the mesial. Once everything was settled, then I did the prosto part. And sometimes you have to take out both, and then the rest is obviously known to the listeners. So number 1, case selection. It is going to be single-rooted teeth and with conical shape, long enough because after extrusion, you're going to have a crown root ratio of at least 1:1 in absence of active infection. And number 2 is atraumatic extrusion. Please understand
Now, before we
this.
get to number 2, I just want to cross off a thought on number 1. So let's go
Sure.
stage by stage, okay? The only question mark I have now about stage 1 case selection is you said no active infection, okay? But what if you do, but you're going to be root canal treating it anyway, and therefore, if it has an active infection but has got potential and structure is looking good, what's the protocol? Like, would you root fill it? But then the problem with actually root filling it is you don't have enough ferrule to put the rubber dam on. So how do we talk about that scenario?
All right. This is the way I'm going to do it. Normally, postpone endo treatment to the time that I'm sure that everything is healed and reattached. However, if you have an abscess, if you have any kind of infection, this is what I do. We do the first stage of endo treatment. We put calcium hydroxide, and then we wait for the symptoms to subside. And then we do the surgical extrusion. Once everything is done and the tooth is reattached to the PVL and the bone and the gingiva and it is stable, we go for the endo treatment and post-encore and the final or temporary restoration.
That makes sense. Okay, great. I'm now fully happy with stage 1 case selection, including the bonus tip of, okay, if you do have an active infection, this is what the SEIF Protocol advises. Yes. Lovely. Stage 2, sir, the make or break, the bit where you're doing it for the first time, you're a little bit nervous, you're sweating because everything now hinges on you taking this root out without it fracturing to pieces, because then you have to say, okay, yeah, we're going to do an implant.
Yes, that is true. That is very true. And that is the very important and the very difficult part, because you have to be able, first, you need to be good at doing extractions. You have to have an expert hand when it comes to extractions, because it is not a normal extraction. When you want to take the tooth out, it has to be done in a very atraumatic way, number 1. So we are talking periotomes. We are talking very delicate forcepses. And you mentioned Benex. I also use that, but not in all cases, because if you want to extract a tooth that is hopeless, when you are trying Benex, even if the tooth breaks, it's okay. But when you promised your patient that I'm saving it for you anyway, that one is a bit risky. Unless the root is very thick and everything, so we'll get there.
So this is because when you use the Benex, I think something screws inside the tooth, right?
That is true.
That's the point where it could induce some weaknesses and propagate a fracture. Is that what you mean when the force applied?
Exactly.
Okay.
Not the force applied by itself. When you are engaging that screw inside the root, that is going to have a wedging effect sometimes, and then it gives you a vertical fracture. So the important part when you are taking the tooth out is you need to make sure that you are not doing it buccolingually. You have to be able to rotate it and take it out. So that's why we are emphasizing on the shape of the root, that it has to be conical. Otherwise, you cannot rotate it and take it out.
So if some centrals, they are in a bit like, not rectangular, but you know what I mean? Like they're very wide-ish. So not like a pure circle. They're more like an oval, right? And that oval one, I didn't know it makes hearts on the screen if I do that. There we are. That's the first time I've seen that. I'm loving this so much, you see. So Vala, so you're saying that the oval shaped one, maybe because you can't really rotate that so well, that's maybe something to consider as not an ideal root morphology.
No. It's not that. Dr. Jaz, if you remember, I emphasized on doing it atraumatically. So atraumatically means minimal manipulation.
Okay.
When I'm asking everyone to do a rotation, it does not mean that you have to rotate. It's not a watch winding. All right?
It's very minuscule. It's a micro movement.
That meticulously, exactly what you referred to, the word that you picked was perfect. It's a micro movement. So please make sure that you're spending enough time on it. There shouldn't be any rush.
How long does it take you? A central incisor, typically from your cases, obviously every tooth is different, every one's different, but like someone might think that, okay, I'm going to spend 5 minutes. Someone say, you know what, actually you might say that typically I spend half an hour and I spend my time. How many minutes, obviously for the novice, it will take longer, but as a guideline, well, how long is a reasonable amount of time spent on this very crucial part?
When I started for the first time, obviously I didn't take any courses whatsoever. Just I was trying to self-educate myself on this. However, we are having courses now, and I'm trying to teach other dentists. For the first time when I did this, exactly like the first, just like the first implant when I placed 16, 17 years ago. It took me 1 hour and 55 minutes. After 16, 17 years, I do the same thing within 14 to 15 minutes. But, I'm not proud of that because we are not, setting a record here. We are doing the correct, perfect job for the patient. Normally, for a routine extrusion, for me, after doing 200 plus cases over 7 years, it takes around 10 to 15 minutes from the start to the end. But 2 weeks ago, I was doing a lateral incisor for a young patient. It took me around 45 minutes to take the tooth out because the fracture line was palatally and very deep. So I needed to spend as much time as necessary to make sure that I'm keeping this tooth for the young patient who came to my clinic with tears in her eyes that I'm too young to lose a tooth. So that comes first. Take as much as necessary to do the perfect job for the patient. Normally, within a half hour, you should be done. But for the first cases, it goes up to 1 hour, which is okay. Practice makes perfect. So no rush.
No rush.
Take your time.
That's the main lesson here. You got to be so delicate and no rush. But again, consent the patient that, look, we're trying our best here, but sometimes the tooth can crack and whatnot. And therefore, we always have our plan B, but we will try our best. Nothing is promised.
Yes, correct.
Has it happened to you before when you try to do it and then actually no, it's fragmented, it's broken, and then you've had to no longer proceed?
Yes, there was but one thing is very important, and that is you must, if you feel that this case is going to be too risky, you must explain to the patient before you touch anything. Because if you are explaining to your patient before you start, it's an explanation. But if you don't and you do the job, and something happens that you predicted, but you did not inform the patient, if you have all of the explanations, that the correct ones in the world, to the patient, it is an excuse. It's not explanation.
Absolutely.
So I tell my patient that, okay, I have done this for so many years. I know what I'm doing, but this specific tooth is too risky. So please understand that I am doing whatever in my power to save the tooth for you. There still is a chance that it fractures, it doesn't work. So be prepared, because if you go to 99 out of 100 clinics, they would take the tooth out and place an implant for you. I'm trying to save it for you. So if something happens, please be aware or understand
That's
this.
That's a good way to frame it, for them to understand that, if you walk into any other clinic, there's always still a plan B, and to be a bit more forgiving. So it's all about, adequate conversations before you do the treatment. Okay, so atraumatic extraction, stage 2. Obviously, you teach this on your courses and stuff, and there's only so much we can talk about it now. But let's just, for the sake of completing the SEIF protocol, case selection number 1, SEIF atraumatic extraction number 2. What's number 3, sir? How do you fixate the tooth?
All right. There are different ways of doing it. Number 1 is they used to suture the tooth. I am not a big fan, because to me it is not reliable. Some others, they actually use wire and composite, which is fine. I have done this. But after a while, I started only using flowable composite, which works for me. But the key here is that do not use too much composite or composite, because it's, number 1 is when you have a bulk of composite there, it is difficult to have it clean. And the other thing is, we are talking about semi-rigid fixation. Semi-rigid fixation allows you to be, actually, it actually prevents from ankylosis and root resorption, which are 2 risk factors here.
Okay, but I'm just trying to visualize this now. The patient's going to walk around with flowable, just like tags, like let's say it's an upper left central incisor. Some flowable is like attached to the fragment and the adjacent teeth next door. So like the central and the lateral. But then that's not a very aesthetic solution. How will you manage the patient expectations in terms of temporization during this time?
All right. How are you going to deal with a patient who has lost enough bone to have an immediate insertion and needs bone grafting and soft tissue grafting, and you cannot give the patient an immediate prosthesis?
Essex retainer with a composite inside or something is a popular choice?
That is a choice, but not all the time you give it to the patient, because sometimes you have to give the tissue enough time and space to heal. Obviously, aesthetic is a big a part of the patient's expectations, but we must understand that, and we must try to make the patient understand that it is a part of the solution that we are having. The patient is going to walk around with that tooth for about probably 4 weeks. So it is much faster than implants in many cases.
Yep.
So basically, no. My answer is always no to a temporary, unless you give the patient an ethics that, and the patient's occlusion and bite allows you to place it inside the mouth and you can relieve around the, for example, palatal part of the root that you have extruded. Not in every case. Initially, I used to give the patient an acrylic temporary crown immediately after I did the extrusion, but I realized that gum healing is not best when we do it. So we really need to talk to the patient before the treatment and discuss everything and say that, okay, this is the healthiest type of treatment that we can do for you. And these are the facts you must understand and try to help you to get the best results.
Okay, so the no temporary, while aesthetically is a downer, it allows for the best healing and cleansability.
That is true.
Okay, great. So now we've talked about flowable as a fixation. Obviously, I'm sure there's more nuances, other ways to do it, but in the interest of time, what's the next step?
The next step is removing the splints. So after 2 to 3 weeks, the patient comes back in, and then we remove the splints. I'm asking my colleagues not to be terrified when they remove the composite and they realize the tooth is still moving, is mobile. It is going to be okay after a while because very mild stimulation on PDL is actually good for reattachment and everything. So after 2 to 3 weeks, we remove the splints. And normally after 4 weeks, I send the patient to our endodontist to do for endo. And then post and core comes. And then we are going to either give the patient a temporary crown or the final restoration, depending on the soft tissue. Because at that time, soft tissue may not be perfect. So we're giving the patient a temporary, wait for a while, and then we will go for the final restoration.
Okay, great. And so that's the full protocol explained, right? That's all of it. Well, obviously, there's so much deeper. Yeah, so obviously you go deeper in your education stuff, but as an overview, it's okay, fine. So what questions do I have at this point? Let's see. So just to summarize, the splint stays on for 2 to 3 weeks, the composite splint. Is that fair?
Yes, correct.
Yep. And then when you remove the splint, that's the same time that you have the endo, or you give it a bit more time after you remove the splint, but before the endo?
Dr. Jaz, when you remove the splint, the tooth is still mobile. And if you are going to do a perfect endo, we know that we have to put clamps and rubber dam is necessary. Sometimes you can put the clamp on the adjacent teeth, but usually I do not risk applying any force on that tooth. So I always ask the patient to wait for a while, and after probably 4 weeks, the tooth is strong enough, so then we go for endo.
Perfect. Okay, so now that's making sense to me. And then the last consideration actually is about post crowns. There are some philosophies that if you have enough ferrule, then you don't need a post, right? Because now our core is being retained by our adhesive system, and therefore we can use the sort of canal space and stuff or the access cavity area, if you like, to get it. So how important do you think it is to have a post? Is this like, in your protocol, it always gets a post? And then if so, does it matter for you if it's a fiber or a metal, cast, that kind of stuff? Tell us a bit more about your philosophies on post, because it's a very popular question we get from listeners, as you can imagine.
All right. Sure, absolutely. Number one is we must understand one thing, that every case might be different from others. So yes, sometimes for some of my cases, there's no need for a post. So a very good restoration, a build-up is going to do the job. Sometimes, because the more and more I go into this technique, the cases that I am treating become more complicated. So yes, most of the times I prefer to go for a post and core. And in many of the cases, I prefer casting posts and cores.
Okay. It adds a bit more time, an extra step, but I appreciate that philosophy, because the more tooth destruction you have, the more rigidity can help you. And basically, people always say about, oh, the fiber post is more retrievable when it fails, the adhesive will fail. But the way I always view it is when that fiber post fails, this is a complete disaster. Who's going to retrieve that? It's end of the line. So why don't you give something that's more rigid and then it's just probably going to last longer overall. Is that your thinking?
I have retrieved many, many, many posts before.
Okay, nice.
Fiber posts, those casting posts, and prefabricated posts, which I call the prefabricated ones the lazy posts. because in my opinion, when there are better ways of doing something for the patient, you always should do that. I understand that sometimes time matters, sometimes it's the cost of treatment and everything, but most of the posts with proper technique and spending enough time, they are retrievable unless they have broken very deep inside the root, and then no, we're done. But you are absolutely correct. When the post fails, it's a disaster.
Fine. So that okay. So your prep is nice to know your preference, cast post. I get it. You've answered all my key questions. I'm so happy. I've really enjoyed it. Dr. Seif, tell us, how can we learn more from you? Tell us about your Instagram page. Tell us about your courses. Are they all in Iran or are they around the world? Are they online? Tell us more about that, because this hour is a really great introduction into the surgical extrusion technique. You've told me you get some papers. Please send them to us so we can make them available. But to have spoken for 8 hours on every little point and shown cases and stuff, and I think that's only fair to do from your education. So tell us more about that.
Sure. Basically, we are trying to connect with other colleagues around the world, especially in Europe, to organize courses, which will be announced later. But in order to have better access to colleagues all around the world and for them to have access to me, I set up an Instagram page. The name is Extrusion Master. It's a in a very humble way, by the way. In a very humble way. I chose the name. So they can follow us on Instagram. I'm going to gradually put up a lot of my cases on that page, along with some good papers. I'm going to have a review on them. I'm going to write my opinion of the way they have done the work, again, in a very humble way. And if also we are having online courses. So for the people who are, for the colleagues that are not able to travel to different countries, or they are too busy, or they want to spend a weekend on learning such techniques, it is available very soon. Again,
so follow the Instagram Extrusion Master to find more information about that, right?
Mm-hmm. Yes, correct.
Amazing. So, Dr. Seif, I really enjoyed the SEIF Protocol, your humility, your storytelling. It was a perfect episode, right? A great introduction to surgical extrusion, great revisit. I know I visited it once before, but it's really nice to connect again, new colleagues, new ideas around the world, and you answered my questions so nicely. I wish you all the best. I'm going to put all your links and everything in the show notes, and I really value your time. Thank you so much.
Thank you so much. Really enjoyed it, and I'm really glad that I texted you many times. I know you are a busy man, but let me tell you this. The last message I sent to you, I was this close to actually delete and unsend it, because I waited for so long for an answer from your side. But I said, okay, it is worth it to send another text to you, because many of my colleagues and their patients, obviously, eventually all around the world can benefit from this. And I would like to add one more thing when it comes to technique, because a few years ago, you talked to a colleague who was an endodontist from the UK, and he mentioned something that I came up with a very simple solution. It helps all of my colleagues. Do you remember when you were chatting with that endodontist? This esteemed colleague mentioned something. He said, when I want to do the bonding, to do the splinting, I'm having a very hard time to do the bonding because the saliva and the blood and everything comes out. You remember that?
Yes.
All right. The answer to that is very simple, my friend. You just take the tooth out, put it back in, blood is coming out. Give it 5 minutes. Don't do anything. Just give it 5 minutes. The bleeding stops, and then you irrigate, and then you can do the bonding without any hassles.
There we are. Yeah. So, actually, how important is the taking it out and put it back in? So, let's say it's a non-endodontically treated tooth. Are you saying that for the sake of bleeding, to take it out and put it back in actually is
No.
a secret? Okay.
No. The secret is once you are done with repositioning, whether you are taking it out fully or you are partially taking the tooth out, obviously you're going to have bleeding.
Yep.
Don't do anything. Leave it there for 5, 6, 7 minutes. Try not to splint and bond and etch and everything. Just give it time. After 5, 6 minutes, once you irrigate and you wash everything, there is no blood coming out.
Amazing. You're the man that keeps giving, man. I appreciate that very much. I'll have to put that episode in the show notes so people can revisit that as well. But yeah, I appreciate you tuning into that, and thanks for the messages. At the moment, sometimes life gets very crazy with the DMs, and I appreciate sometimes that's the best way people to reach out. But I'm so glad we did get this to arrange. I want to thank manager Alex who helped arrange this and the team. So this was an absolute goldmine of information. And hopefully, if you're in the UK one day, we'll go out for some food and catch up again. It was very, very lovely to talk to you, my friend.
Same here. I really appreciate it. And thanks for having me. And I hope that we have a chat in the future sometime soon.
Absolutely, my friend. Well, there we have it, guys. Thank you so much for listening all the way to the end. And even right at the end, he gave us that little tip. The previous episode we did, which was episode 61, 4 years ago with Dr. Peter Raftery, I'll put that in the show notes. I'll put any papers that Dr. Seif sends me. I'll put the link to his Instagram, Extrusion Master, so you can see his cases and papers and join his courses and that kind of good stuff. And I just want to thank him again for being such a wonderful guest. I want to thank you for liking this video, subscribing, or if you're on Protrusive Guidance, the nicest and geekiest community of dentists in the world, please do drop a comment as well. And if you're not on our community, what are you waiting for? We have so many premium clinical videos, webinars, vertipreps for plonkers, the whole shebang, it's there. Head over to protrusive.app to discover more. We are a PACE-approved education provider, so if you are on Protrusive Guidance, scroll down, answer the quiz, and claim your CPD. You've done the hard work, you've listened, you've learned. Now it's time to validate with reflection that forms part of your PDP and a certificate that's valid everywhere in the world. Thank you again, dear friends, and I want to thank Team Protrusive as ever. I'll catch you same time, same place next week. Bye for now.